Bismillahirrahmanirrahim. First of all, thank you to all of you to join this session, which is related to the parasympathetic pharmacology. And if you remember that in the last session, we have discussed about the sympathetic pharmacology. So both of these systems, as a part of autonomic nervous system, they are very much coordinated and related with each other, although opposites in their functions, pharmacological functions and the physiological functions. So first of all, please let me know that my voice is clear. I am not going so much fast, I am not going so much slow. Okay. So before the start of our this session, I just want to fresh your memory and recalling about the sympathetic pharmacology that we have discussed about the sympathetic nervous system, what type of the receptors are involved, what type of the neurotransmitters are involved, what type of the sympathomimetic drugs are involved, what type of the sympatholytic drugs are involved, and their clinical as well as the pharmacological or the therapeutic use in the previous sessions. In the same line or in the parallel, you can say we will also discuss the parasympathetic pharmacology. And remember one thing, that as I told you earlier in the first session, that when one of our system it is activated or stimulated, then ultimately the second one it is at the lower level, or you can say that at the zero level. And if you remember that diagram in which I let you know in the previous session, that if one boy he is running and there is behind a snake, ultimately at that time his sympathetic system it is more activated or more elevated, you can say that. And at that time his parasympathetic system it is at the zero level into that diagram. And in the second you can say part of the diagram, if you see and recall in your memory, that when a person he has enjoyed some good meal, KFC, McDonald's or Albec, and he's in a resting and relaxing phase, then his sympathetic system it is at the zero level. So what it means, that it means that both the parasympathetic and sympathetic systems they are actually coordinating with each other in the same systems. Means the sympathetic and parasympathetic innervation or the nerve stimulation it is present in both organs at that time, but actually one system is more activated and one is inhibited at that time. Sometimes it may happen that both systems you can say that they are in the active phase, but one it would be more active and the other it would be lesser active. But usually it happens that when we are relaxing, our parasympathetic system is more active, and when we are in a situation of fight, flight or fright, at that time our sympathetic system it is activated. So everybody is clear still now? I just want to refresh your memory about our previous lecture or the first session. Okay. Second, if we comes the learning objectives of today's session. I'm so sorry that what is happening with the slide share. Yeah. Learning objectives. By the end of this session, you should be able to classify the main types of parasympathetic receptors as we have done in our first session. There we actually classified the sympathetic receptors. Now here we will actually discuss the parasympathetic receptors, their classification. Second, outline selective cholinergic agonists and antagonists. At that time in the first session we discussed the sympathetic agonist and antagonist. In the meantime now we will discuss our selective cholinergic or parasympathomimetics agonist and antagonists. And then we will discuss the mechanism of action of parasympathetic drugs. Either they are the stimulants or depressants. I will use the word blockers because depressant it is a just not odd word, you can say that, but when we have to say the stimulant, then ultimately the suitable word it is the depressant. And then we will discuss about the common clinical uses of parasympathetic drugs. Either they are the stimulants or the blockers. So everybody is clear about the learning objectives of our today's session. Okay, that's fine. So next we will proceed towards the outlines of our today's session according to the objectives. So first of all, we have to see the parasympathetic receptors, its classification or types. Then we have to discuss about the parasympathetic stimulant drugs, direct or you can say that indirect, their mechanism of action, some of their common clinical uses. And if you see that we have parasympathetic stimulants and parasympathetic depressants, means muscarinic blockers, as well as you can say that the muscarinic stimulants. And as well as we will discuss some of the nicotinic stimulants and blockers. Why? Because if you see in the sympathetic stimulation, we have two types of receptors. One is alpha and one is the beta. And same is the here case that we have two type of receptor. One is the muscarinic and other is the nicotinic. So it means that when we have the muscarinic agonist, we definitely have the muscarinic antagonist. And when we have the nicotinic agonist, we definitely have the nicotinic antagonist. So this is actually the simple outline of our today session. Before the start of our active talk, I want to clear you something. I think I missed one or two slides in our last session, and some of the students they were complaining because I could not receive the appropriate lecture from the concerned person. But if you people don't mind, just give me a few minutes that I can recall your some of the knowledge related to the sympathetic pharmacology while sharing one or two slides, so that you must be very well aware that what is actually the sympathetic nervous system and the difference between parasympathetic nervous system. If you don't mind, please, I can share you now some of the slides from the previous session just to give you a brief difference about the sympathetic nervous stimulation as well as to the parasympathetic nervous stimulation. So first of all, this is from the previous session, that if you see that sympathetic nervous system, it has the thoracolumbar outflow. What it means that the thoracolumbar outflow means that most of the nervous system preganglionic and postganglionic fibers which are coming from the spinal cord and the central nervous system, it actually has T1 and T1 to L2 distribution into the sympathetic nervous system. You can say that most of the nerves, you can say that they are actually have the thoracolumbar, you can say, distribution. And specifically in the sympathetic nervous system, we have the thoracolumbar distribution of the nerves. You can say that from the spinal cord as well as from the central nervous system. And in this central nervous system, sympathetic nervous system, there are two type of the ganglia. That is the paravertebral ganglia and the prevertebral ganglia. If we see the paravertebral ganglia, they are much closer to the spinal cord. You can say that, okay, from where we have the thoracolumbar outflow of the nerves, you can say that. And then we have the prevertebral ganglia, some of the prevertebral ganglia which are near to the effector organ. So what it means that, it means that the nerve stimulation in the sympathetic nervous system, it has paravertebral ganglia and the prevertebral ganglia just to reach to their effector organs. But if we comes toward our today's session, I will let you know a difference here. Just give me a minute, please. Yes. If we come towards our parasympathetic system, it has a, I'm so sorry. Yes. If you see our parasympathetic system, it has a craniosacral outflow. But it means that there is no prevertebral ganglia or there is no paravertebral ganglia. Only the nerves, they are coming from the spinal cord and the central nervous system, CNS. So here are four cranial nerves which are coming from the central nervous system. These are 3, 7, 9, and 10. And they are actually, you can say that, innervate different organs or different smooth muscles of your body. Like if you see that the third cranial nerves, it actually supply the nerve to your sphincter muscles of the iris and the ciliary muscles of the eye. And if you see 10, cranial nerve 10, it innervate your heart, lungs, stomach, and small intestine, bile ducts, kidney, large intestine. To some extent, you can say that large intestine. But if you see the seventh cranial nerves, it has the function in lacrimal gland into your eyes to produce some secretions or tears. It has also role into submaxillary and sublingual glands in your mouth to produce, you can say that mucus as well as saliva. And the ninth, it actually has some of the activity into the parotid gland. It is also a gland in front of your ear and sorry, behind the ear and the bones of your face, which actually produce some type of the serous secretions. And if you see the cranial nerves, they are actually, you can say that, involved in most of the smooth muscles activity from the central nervous system. But if we see the spinal cord, there are three nerves. One is S1, S2, and S3. So S2, S3, and S4. Yes, parasympathetic, they don't have any preganglion. Yes, preganglion and paravertebral ganglion, you can say that, parasympathetic. But the sympathetic, they have the paravertebral and the preganglion. Clear? Yes, I'm so sorry. I am so sorry. I'm not using the cursor. So yes, here is the sacral spinal cord nerves, three, S2, S3, and S4. So these, you can say that nerves, they actually supply to large intestine, bladder, genitalia in female, and uterus in the females. So if you see that the parasympathetic, they have the craniosacral outflow. What it means that craniosacral? Craniosacral outflow means that four cranial nerves which are actually supplying to eyes, heart, lungs, stomach, small intestine, bile ducts, kidney, and to some extent large intestine, lacrimal gland, submaxillary, and parotid glands, they are innervating from the central nervous system part of the adrenal medulla, not from the spinal cord. But to bladder, genitalia, uterus, and large intestine, there are three spinal cord nerves that is called actually the sacral spinal cord nerves, S2, S3, and S4. And there is no involvement of the paravertebral or prevertebral ganglia in the parasympathetic stimulation. Everybody is clear? Up till now, the distribution of this craniosacral outflow or the nerve distribution into the parasympathetic organs, all responses are from the female side, no response from the male sides. All the males are sleeping, having some activity, or they are eating something or drinking something. So I also need some response from the male students as well, if they are in this group. Okay, so until now, if there is nothing clear, please let me know. If there is any question, please let me know so that we will go into the second part of our talk. Everything is clear? Okay. So next, coming towards autonomic transmission, that how impulse is conducted in the parasympathetic nervous system. If you see that in the sympathetic nervous system, as I told you, that there is first of all arrival of action potential. We are talking about the parasympathetic nerve flow or impulse flow in the nerves or the neurons. There is the arrival of action potential, and this action potential, it actually cause increased calcium influx, means most of the calcium, you can say that it is actually coming out from the inside vesicle to outside, you can say. And when this calcium influx it increases, ultimately the acetylcholine neurotransmitter into the vesicle, they are stored as a vesicles into the nerve. they are actually start a process of exocytosis. Exocytosis means that they are actually releasing into the form of some vesicles into the synaptic cleft. And this release of neurotransmitter, it happens into the form of some of the vesicles into the synaptic cleft. This is the synaptic cleft. This is the presynaptic nerve, and this is postsynaptic, you can say that. Then this neurotransmitter acetylcholine, it makes a complex or binding with the receptors to the effector organs, or you can say that the post nerves. And ultimately, after producing the biological changes, there is a removal of the neurotransmitter. So if you compare this autonomic transmission in the parasympathetic system with the sympathetic system, you will see some differences. And what are those differences? If you recall or refresh your memory, in sympathetic nervous system, when there is an impulse, some of the norepinephrine, after producing their effects, it is reuptake into the presynaptic nerves. But here there is nothing, means no acetylcholine, it is going back into the vesicle for the storage, that some type of help of a transporter. So the neurotransmitter acetylcholine, it produces its pharmacological effects or biological effects by binding to the receptor, and after that it is degraded while binding to some type of the other enzymes. I will let you know into the next slide. So there's a big difference between the sympathetic nervous system transmission and the parasympathetic nervous system transmission, that when there is an action potential in the parasympathetic nervous system, the acetylcholine or the neurotransmitter, it is not degraded, it is not reuptake, you can say that again, for the storage. It is degraded by some specific type of the enzyme while binding to the postsynaptic nerve membranes or even to the effector cells. Is everybody is clear about the autonomic transmission in the parasympathetic system? Any question? Any questions till now? Okay. Now this picture, it will clear you more about the cholinergic transmission. The next one, you see here that, and please, I want the attention for all of you. These are the parasympathetic or sympathetic preganglionic fiber or parasympathetic postganglionic fiber. What means that? It means that if you remember that I told you that there are two body organs or two body tissues in our body which are or which have the sympathetic receptors, but they are innervated by the parasympathetic nerves. Anybody know who are those ones? Did you understand my question? That what is my question? My question is that if you recall your previous knowledge of the first session, I told you that there are two body organs or two body tissues in our body which has the receptors of the sympathetic nervous system like alpha or beta receptors, but they are controlled by the parasympathetic nerve stimulation. Yeah, very good, Miss Jamana. If I'm so sorry that if there is some pronunciation, wrong pronunciation of your name, Miss Allah and Miss Jamana, they have the good answer. That is sweat gland. And second one, sweat is the one answer, and the second part of the answer, it is the erector pilar muscle. So what is the erector pilar muscle? No, there is no blood vessels. Erector pilar, the erector pilar muscles in skin. Yeah, hair follicles. Yes, it is called actually the erector pilar muscle. Erector pilar muscles are the muscles. You know, when someone is frightened, if you have some type of scareness in dark, or you can say that even you have seen some snake, the hairs on your legs, on your arms, or some body parts, it becomes erect, it becomes straight. You understand? Huh? This is actually the stimulation of the erector pilator muscles of the hair, that your hair it becomes straight on your body parts. I'm not talking about the hairs on the head. I am talking about the head, on your legs, on your arms. That when you are frightened, unsudden frightened, you can say that, or when you have seen some dangerous animal, then ultimately the hairs on your body organs like arms and legs, it becomes erect or straight. So this is actually the activity of the sympathetic stimulation. So it means that your sympathetic nervous system, it is stimulated. So this organ, that is the erector pilator muscles, you can say that it is actually a sympathetic nervous system. Alpha or the beta receptors are involved, but it has the nerves stimulation from the parasympathetic nervous system. Everybody is clear? So here means that the preganglionic fiber, they are only in the sympathetic. So when there is the synthesis of acetylcholine, there is an action potential, or you can say that nerve stimulation, it will cause influx of calcium, and then acetyl CoA, an enzyme from mitochondria, it is released, and choline from outside of the nerve, it makes a complex with this enzyme acetyl CoA, and it produces the acetylcholine. This acetylcholine, it actually, you can say that, form in the form of vesicles, and when there is an action potential in the form of calcium, then ultimately it is excreted in the form of some exocytosis. So this formation of the vesicle is called actually the process of exocytosis. Not Miss Namara bind to the receptor. We're just talking about the exocytosis. So exocytosis means that when acetylcholine is synthesized into the preganglionic fiber or parasympathetic postganglionic fiber, then ultimately it is stored in the form of some vesicles. When there is an action potential, this calcium influx, it is increased, and when this calcium influx is increased, this acetylcholine, it is released into the synaptic cleft into the form of some vesicles, and this vesicle formation is called actually the exocytosis. And now just see here, please concentrate on this figure now. This acetylcholine from synaptic cleft, it will actually bind to the nicotinic and muscarinic receptors to produce its pharmacological biological effects onto the effector cells. Okay, but here if you recall your first talk of the sympathetic nervous system, no acetylcholine is going back or reuptake, as we have seen in the norepinephrine case. That norepinephrine, it actually reuptake into the presynaptic or preganglion fiber. So here is nothing happening like this. So what it means that, it means that when acetylcholine it produce its pharmacological effects, after that it has to be metabolized into the synaptic cleft. So what it will do, it will actually make a complex or binding with an enzyme that is called actually acetylcholinease esterase enzyme. This acetylcholinease esterase enzyme, it degrades the acetylcholine. When acetylcholine it has produced its function, and after that it is metabolized or leave this synaptic cleft in the form of some acetate or the choline. So everybody is clear now, the synthesis of acetylcholine, its pharmacological action and its fate, or you can say that its metabolism or degradation. Everybody is clear? Any questions till now? Okay, so yes, until now I have told you that what is actually the distribution of the parasympathetic nervous system, what type of the nerves are contributing to the uh, functions of the parasympathetic system in different smooth muscles as well as in some of the skeletal muscles, what are the neurotransmitter involved in the parasympathetic neurotransmission, what is the synthesis of acetylcholine, how it is, you can say that, degraded after producing its pharmacological effects, and how it released into the, or from synaptic cleft into the metabolism form into the blood, and after that from blood into the outside environment. So first of all, after that we will see the cholinergic receptors. As we have seen in the case of sympathetic nervous system, we have the same case here. Cholinergic receptors. As we have seen in the sympathetic nervous system, there are two types of receptors. One is alpha and the other is beta. And even in alpha and beta, we have alpha 1, alpha 2, beta 1 and beta 2. And same is the case here, that we have two types of the cholinergic receptors. When we say the cholinergic receptor, it means that these receptors, they work on by binding of the neurotransmitter acetylcholine. Clear? So this is the reason that why they are called the cholinergic receptors. And if we see the classification of the cholinergic receptors, we have two types of receptor. One is the nicotinic receptor and the other is the muscarinic receptors. So if we see their distribution, first of all, their mechanism of action, we will also discuss in detail in the next slides. They act by depolarization. So what is depolarization actually? Anybody knows what is depolarization? What is depolarization? Can you hear me? Yes, changing the polarity inside cells. Okay, that's fine. Any other answer? When we have action potential, yes, the question is that what is depolarization? Yeah, okay, action potential. Yes, a stage in action potential from negative to positive. Okay, that's fine. Any other answer? Okay, stimulates the nerves. Any answer from the male side? All the answers are from the female sides. It means that they are more active. In normal life, males are more active, but here I am seeing that the females are they are more active. It means that they are following the things. So yes, all the answers they are right. What means that actually the depolarization? Depolarization means that when there is an action potential, okay, there are two phases. One is depolarization and one is repolarization. When when an action potential it transmit from one nerve to another nerve, it becomes depolarized. What is the meaning of depolarization? Depolarization means that to make more positive charge of the nerve instead of the negative charge. So when a nerve is depolarized, then ultimately the action potential it flows into that nerves. Okay, and when there is a repolarized state, then ultimately negative is more than the positive. So this is a difference you can see that between the depolarization state and the repolarization state. And by the way, it both of these states you can say that it happens when we have a nerve impulse from our or action potential from our central nervous system, or even you can say from the spinal cord. So if we see the distribution of the nicotinic receptors, there are two types of the nicotinic receptors, and N they are present in the autonomic ganglia. No, Mr. Maz, the cells become more negatively. No, when there is depolarization, the cell becomes more positive. Means the charge on the surface of the cell membrane is more positive. It is depolarization. And when there is repolarization, then the membrane surface of the cells they become negatively charged. It is a relaxing phase. You can say that depolarization is an active phase of the action potential. The repolarization is the you can say that relaxing phase of the action potential. So nicotinic receptors they are present in two major body organs. One is NN that is in the autonomic ganglia and adrenal medulla, and one that is NM that is in the neuromuscular junctions or the motor end plates. So this is the distribution of the cholinergic nicotinic receptors. And when we are talking about the cholinergic muscarinic receptors, we have the five classifications or the five you can say type of the muscarinic receptor. One is the M1, second is the M2, third one is the M3, and 4 and 5 also. So if we see the M1 receptors, they are mostly present in our gastric glands, means in our GIT. You can say that in some of the secretions like lacrimal gland, they are present, and they act by increased intracellular calcium. Means there is when there is an influx of the action potential of calcium, then most of these receptors they are activated. M2, they are present in the heart and in the presynaptic sites, and they are acted by decreased cyclic AMP. Means M2 receptors, they are causing bradycardia. When our parasympathetic system is activated, then ultimately there is lower production of cyclic AMP, and it will actually cause the activation of M2 receptors to produce a bradycardia in our heart. M3, they are present in glands and smooth muscles, like you can say that in some of the genitalia in the male and female, and as well as you can say that in some other parts of our parotid glands. And ultimately they have also the same stimulation by the increased intracellular calcium influx. And M4 and M5 receptors, they're present in the central nervous system, and they are also innervated, or you can say that they are also stimulated by the increased cellular calcium influx. So everybody is clear about the distribution of the nicotinic and muscarinic receptors? Am I going so fast or so slow? Yes, there is a question that either nicotinic receptors are present in the central nervous system. Yes, there are adrenal, as I told you, the adrenal medulla. Some of the nicotinic receptors, they're present in the adrenal medulla part of the central nervous system, or of our brain, you can say that. IC means that intracellular calcium. I for intra, C for cellular, calcium is calcium, intracellular calcium. Means most of the muscarinic receptor like M1 and M2, M3, they are activated when there is increased influx of calcium. We will discuss in details in the next slides as well. So everybody is clear related to the cholinergic receptor distribution? Any questions till now? No. What is the problem, Miss Reena? That why are you not clear? What is not clear to you? Please, can you write or can you speak just to let me know that what is not clear? One student is not clear about. Okay, if there is no question, then fine. It means that you are following me. If you see the next slide now, please, I want your attention. What this shows you? This shows you, as I explained you, yeah, cyclic AMPS. I know that this type of questions from you people. Actually, when a neurotransmitter, it binds to its receptor like acetylcholine, you can say that. Okay, when it will bind into the receptors, either M1, M2, M3, or M4, then ultimately you can say it will not go inside to the target organ or the effector organs. The effector organs, they have some specific type of the molecules which become activated or stimulated to produce the pharmacological effects. These are called actually some type of the modulators like G protein. You know that G protein coupled receptors, you can say that. Cyclic AMP, the ATP, adenosine triphosphate, you can say that. ADP, conversion of NADPH into NADP. So all these are the modulators, you can say that. And I think some of your modules which are very much related to the biochemistry as well as to the physiology, they can better understand you that what are those modulators inside the cells. When a receptor when sorry neurotransmitter binds to receptors, then intracellular a lot of modulators, they are become activated just to produce the pharmacological or the biological effect. Is it clear now? Yeah, why it acts by low? Because it is a parasympathetic nervous system. It is a stimulation of parasympathetic nervous system. This is a very, very good question, you can say that. Okay, when our heart rate is increased, okay, so our heart rate is increased by sympathetic nervous system stimulation. Am I right? When our heart rate is increased, it is increased by the sympathetic nervous system stimulation. So what it means that at that time the cyclic AMP is increased. But now here is bradycardia, because parasympathetic system, as I told you, it is a relaxing phase. It is a rest phase. Our blood pressure is normal, you can add, or below the normal. Then ultimately the cyclic AMP, it would be decreased because it is yes, cyclic AMP, it is stimulated by the sympathetic system. Yes, it is stimulated by the sympathetic system to increase the blood pressure. You understand, huh? Increase the blood pressure. Here in parasympathetic system, it is also stimulated by the acetylcholine, but it decrease the cyclic AMP production because the receptor is different as well as the neurotransmitter is different. If you see the sympathetic system, the neurotransmitter is norepinephrine, clear, and the receptor is beta. Here the receptor is muscarinic and the neurotransmitter it is acetylcholine. Understand? So when there is sympathetic stimulation, ultimately norepinephrine, it will stimulate the beta receptors to increase the cyclic AMP, and ultimately blood pressure is high. And in parasympathetic system, when acetylcholine, it will act on the muscarinic receptor, it will low down the cyclic AMP just to reduce the blood pressure. Everybody is clear? Everybody is clear or still not? Okay, I think the next slide it will give you more idea, more better idea. So please wait for the next slide. I am going here now. Now it must be more clear to you. So what these slides show you? What is your guess? Please let me know. Have a frank talk when you are learning. When there is a knowledge, you have a frank talk. Please. What is your opinion about seeing this picture? Which type of M? I don't understand. Lower hand. Someone has lower hand. Okay. Raise hand or lower hand, I don't know, means when there is a question we have to lower the hand or raise the hand. If there is any question, please. Okay, yes, there is one thing from one student. Okay, so this picture, if you see and focus your mind, it let you know that both sympathetic and parasympathetic system, they are innervating your eyes. Clear? Yes, this is a very good answer from Miss Maha. Effect of both on the eyes. So what it means, that it means that every body system or body organ, yeah, every body system, and Miss Aziza, the different, yes, yeah. So everybody, every body system or organ or muscle, it has at the same time sympathetic and parasympathetic nerve stimulation at the same time, parasympathetic and sympathetic. But it depends on the situation, that in which situation we are working on, we are going on, then one system it must be more active and one it would be, you can say that, less active. Like if you see here in the eye case, both sympathetic and parasympathetic, they are working on. Okay, if you see the sympathetic, yes, Miss Asma, is there any question? Yeah, I will let you know. Don't worry. Which type of muscarinic receptor? Don't worry. So if we see in this sympathetic and parasympathetic, both they are innervating to the eyes. But if you see here, the sympathetic system, the receptor is alpha 1. And when this system is activated, we have the dilate papillary muscles of the eye. So it means that it will actually increase the size of your cornea. There is dilation of the papillary muscles of the eye. There is active mydriasis. We become more active. Our eyes, it can see more far objects, you can say, more alert. But if we have the activation of parasympathetic system, it actually constrict the papillary muscles and it will cause meiosis. Means when we are relaxed, when we are in a state of rest, our cornea, it is, you can say that, constricted. We cannot focus on to the far objects or alert, you can say that. So it means that at the same time we have the innervation of the action potential from sympathetic and the parasympathetic nervous system. Okay, but the receptors are different in both cases and the actions are different in both cases. It depends on the situation. And if you see this parasympathetic, it has also some additional effect on the ciliary muscles, which actually involve for the accommodation of near vision, as well as you can say that decrease the intraocular pressure when there is constriction or the meiosis, or you can say that constriction of the pupillary muscle. Now everybody is clear that every time we are innervating both from sympathetic and parasympathetic nervous system, but which system is activated, it depends on the situation, that in which situation we are going on, which type of work we are going on. Okay, clear? This is one example. You will be more clear in the second example. Yeah, when we are in the fighting situation, our sympathetic system is activated and it will dilate your pupil muscle of the eye, your cornea, it would be more larger, dilate. Then ultimately you are more alert, you can see the far objects very clearly. But when you are in the resting state, your parasympathetic system, it is activated and you can not focus, or you can say that your attention, it is deficit for the far objects or for the alertness. Next picture, it will clear you more thing. Yes, which type of muscarinic receptor? Yes, from Miss Asma, it is mostly M1 receptors, you can say that, in the eye. In the eye there are M1 receptors, you can say that, which are uh, when with the parasympathetic stimulation, these receptors, you can say that, they become active and ultimately we have a meiosis or the contraction of the pupillary muscles. Now this picture, it will clear you the more things about the GIT and UT, urinary tract. Means when there is a sympathetic system stimulation, means when you are fighting, when you are flying, or when you are fighting, your stomach, it is relax the walls, means there is food but digestion is slow, there is no or small secretion of the hydrochloric acid, beta 2 receptor stimulation. The food is digesting but slowly. What it means that when food is digesting slowly, the sphincter of the stomach muscle, it is close or contract, so that no food it can pass from stomach to the small intestine or large intestine for the absorption, because food is not digested properly when you are in a fight, flight, or fright situation, you can say that. And it actually contract the sphincter, so a slow release of food, it may happen from stomach to the small intestine or the large intestine for the absorption, distribution, and after that the metabolism. But if you are in a parasympathetic state, in a relaxed state, means today is weekend and most of the people at night, they will go to enjoy their Albac, KFC, or McDonald's. So what happens at that time? When you are in a relaxing phase, the stomach walls, they are contracting, means they are producing more hydrochloric acid to digest the food, increase secretions. There is more motility of the walls of the stomach just to digest the food very well in a very quick time. And at that time, you can say that when this digestion is very fast, ultimately the food movement through the sphincter, it must be very fast because it relaxes the sphincters. Because when there is a digestion of the food, then ultimately it has come into the small intestine for the absorption and distribution and give the nutrients to the other part of body like liver, brain, blood, heart, this and that. So if you see that in both systems, the receptors are different, function is different, and stimulation is different, you can say that. So what it means that every time our parasympathetic and sympathetic system, they are in an active phase, you can say that they are working on, but which system is more active and which is less active, it depends on the activity which we are doing. Everybody is clear until at the GIT level? Any question? Any question from the male? Is every male is awaking, or all are they sleeping? or they're not following me, or am I making more noise, or someone is not like my noise or voice, sorry. So the same is the case here. Urinary bladder means when your bladder is filled, you have a micturition reflex, then ultimately the urinary bladder, it is relaxed, it is dilated. And same is the case with the sphincter, means when you have an urgency of the urination, at that time you can say that your parasympathetic system, it is activated, the urinary bladder is dilated, and as well as the sphincter, just to pass the urine. But just imagine that when you are doing exercise, when you are fighting or fighting, even you have some urgency of the urination or micturition reflex, but at that time your urinary bladder is contracted, and the receptors are different here. In contraction of the urinary bladder, it is beta 2, and contraction of the sphincter, it is alpha 1. So what it means, that if you see from your brainstorm ideas, that our sympathetic system, it involves more more receptors for the regulation as compared to the muscarinic, or you can say the parasympathetic system. It is more organized, in other words you can say that, because the state of flight, fight and fright, these are not the manageable, you can say that, situations every time. So it means that it is regulated by more actions involving more receptors as compared to the screening or the relaxing state. So everybody is clear. Then we will go into our next, what is on A1 in stomach. It is not A1, it is alpha 1 receptor. As I told you, if you recall your previous session of the sympathetic stimulation, I told you that the distribution of alpha 1 and alpha and beta receptors, they're present in every smooth muscle organ as well as the muscarinic receptors. And believe me that if you remember or memorize the functions and the distribution of, it is a contraction of the sphincter muscle, this muscle, which actually pass the food from stomach into the small intestine or the large intestine. It is the contraction of this sphincter muscles, you can say that, because the food after digestion, it comes from stomach into the small intestine by this muscle, that is called sphincter muscle. Is Miss Asma clear? Is everybody clear, or something not clear? There's no answer. How the wall relax? Yes, when there is a stimulation, like suppose when you have taken your meal like Albac, McDonald or KFC. After that, I am so sorry that there is some interruption. Yeah, relax means dilate. Yes, just give me 1 minute. There's something wrong with the blackboard. Okay, just see the situation. Yes, yes, Mr. Smart. There is any question? Yeah, what is urinary bladder alpha 1? Yes, you know our urinary bladder, this, it actually, I'm so sorry, I will just use a pointer. I'm just using the pointer, sorry. What is the problem? I don't know. Yeah, if you see, this is the urinary bladder. Okay, when our urinary bladder is filled, it would be in this state. Yeah, it's called a sphincter. Yes. So when our urinary bladder is filled, it would be in this state. Clear? And when we have a urination reflex, at that time, this bladder, it is filled, and the sphincter, it is relaxing or dilate. And at that time, our parasympathetic system, it is stimulated. But when we are in a situation of fight, flight or fright, even our bladder it is filled, but it is contracted just to manage the urine, and sphincter is closed because we cannot make urination, because when we are in hurry and we have to get a car, a flight, and you are running, you are in the end hours or in the end minutes, and if you are feeling the urination, you cannot make a urination at that time. Your urinary bladder it is contracted by beta 2 to manage the urine in the bladder, and your sphincter is constricted, that no urination it can pass out. Everybody is clear? Should I go to the next slide? Okay. Yes. Then, just like, okay, Mr. Waleed, thank you so much. I think from the last 50 minutes, this is the first response from a male guy that they are following me. Okay. So if we see the acetylcholine synthesis, as we have seen the the norepinephrine synthesis in the sympathetic nervous system, first of all, it is a natural neurotransmitter. Yeah, I am. Yes, I know that, Mars. No, you are. No, you are from the male side. I know that, but this is the first response I am seeing that from the last 15 minutes. I'm sorry. I'm just kidding. Sometime if you have a huge burden on your brains, you have some type of the kidding like this. Okay, so please don't mind and please don't get it on your nerves. Okay, so I'm just kidding. So acetylcholine synthesis. First of all, you must know that it is a natural neurotransmitter, means it is synthesized in the body, and it has some type of choline ester in the composition, means the chemical composition it is a direct parasympathetic choline ester, means one molecule is choline and other is some ester. And it is rapidly metabolized by choline. And there is some question I think from Miss Lena. I don't understand that, why, what is the question, and even I could not see the question. Is there any question from Miss Lena? Okay, so if there is no question, we may go for things. I'm so sorry that the next slide. Yes. So it is rapidly. Yeah. Why is the bladder contracted if beta 2 is working on it? No. Yes. If you go in this slide, if you go again in this slide, this beta 2 it is only regulating the activity of filling of the bladder. Okay. When our bladder is filled, as I told you, if you see here, if our bladder is filled and you are in a running situation, this beta 2 receptor it will only contract the bladder. It has no role onto the sphincter. Only the beta 2 receptor it is stimulating just to contract the bladder to manage the urine volume inside the bladder. Alpha 1 receptor it is managing the sphincter, opening or shut, contracting, you can say that. So both alpha and beta they have the different functions in the urinary bladder contraction and constriction, or you can say constriction of the sphincter muscle. So alpha 1 it is actually constricting the sphincter muscle, not opening the muscle, the sphincter, just to release the urine. But this beta receptor it is actually managing the urine volume in the urinary bladder. Now clear, Miss Lena? Okay, thank you very much. I am so sorry that if I am not make the right pronunciation of your names, because some of the names in Arabic, to be very honest, okay, they are used for males in the third world countries. Uh, I'm so sorry if my pronunciation is not good, and Arabic, it is not my native language. So acetylcholine synthesis. So first of all, forget about these cross. Okay, so first of all, how we will see that how acetylcholine it is synthesized. As I told you that there is one molecule that is choline, and this choline it is transported through some carriers from outside nerve termini into inside the nerve, and this choline, it will binds with this active acetate inside the nerve termini, and then it will produce the or synthesize the acetylcholine. And this choline, you can say that when it come into the inside the nerve termini, it actually makes binding with this active acetate in the form of in the presence of one enzyme that is called cat. Cat means choline acetyl transferase. So this enzyme, it is very important to make a binding between choline and active acetate to synthesize acetylcholine. So if this enzyme is not present, then ultimately choline is here, active acetate is here, but there is no synthesis of the acetylcholine. And when this acetylcholine, you can say that it is synthesized by the combination of this choline with this active acetate, then there is increased calcium influx or action potential. And when this increased calcium influx happens due to some nerve impulse from the brain or from some spinal cord, then ultimately these acetylcholine, it is actually stored into some type of the vesicles. And when they are stored into some of the vesicles, then ultimately there is some nerve stimulation, it will come, and ultimately the acetylcholine, it would be released into the synaptic cleft, and from synaptic cleft it will bind into the muscarinic receptor of the effector organs to produce their pharmacological and the physiological or the biological effect. So this is a simple, you can say that, explanation of acetylcholine synthesis into the presynaptic or postsynaptic nerve terminal of the parasympathetic, you can say, nervous system, as well as you can say that they're binding to the effector organs. But there are some points, you can say that, where if acetylcholine synthesis is stopped by chance, or you can say that by some of the drugs, then ultimately it is a problem. You can say that there are a lot of pathological states, there are a lot of disease which may happen, that if this acetylcholine, it is not produced properly, if it is not, you can say, stored properly, if it is not released properly into the synaptic cleft, then ultimately we have a lot of, you can say, that pathological states, which I will discuss into the next slides. So the first thing is that if we see the first cross, what it means, that there are some drugs like this hemicolonium. This hemicolonium drug, it actually binds to this carrier, which inhibits the transportation of choline from outside to inside of the nerve termini. So it means that when there is no transportation of choline from outside to inside, active acetate is there, but here is no choline, then ultimately there will be no synthesis of the acetylcholine, and the muscles, you can say that, it would be flaccid or paralyzed. The second thing is that the second cross, there is another drug that is triethylcholine. This triethylcholine, it inhibits this enzyme that is choline acetyl transferase. This this choline acetyl transferase, it makes a binding with choline and active acetates to produce the acetylcholine. So what it means, that choline is there, active acetate is there, but if this enzyme is not here, then ultimately there is no production of the acetylcholine. Everybody is clear? These two inhibitors still now? Any question? Clear to male one as well? Okay, Mr. Turkey. So up till now, acetylcholine, it has been synthesized. Now it has to be stored. But if this storage is not proper, then ultimately there is a problem, that this acetylcholine, it will not comes into the synaptic cleft, and then ultimately it cannot bind to the muscarinic receptor. So it means that for this acetylcholine storage, you can say that acetylcholine storage, yeah, second inhibitor, yes. A second inhibitor is the triethylcholine. It is also a type of drug or a molecule which actually inhibits the enzyme that is actually the choline acetyl transferase, cat. C for choline, A for acetyl, T for transferase. This enzyme, it actually makes a complex with active acetate and choline to produce acetylcholine. If it is blocked or inhibited by some type of the drug molecules like triethylcholine, then ultimately choline is here, active acetate is there, but this enzymes, it cannot make a complex with these two, and ultimately there is no acetylcholine synthesis. Is it clear now, Miss Maha? Then we comes towards the storage. As I told you that this storage in the form of veg is very much important just to release acetylcholine by the process of exocytosis. So there is one drug that is actually vesamicol. This is a trial drug or experimental drug. It means that it is not used in the clinical or the pharmacological prospects, but this is the experimental drug. It actually inhibits the storage of acetylcholine into the vesicle form. And when the acetylcholine it is not in the vesicle form, then ultimately it cannot be released by the process of exocytosis into the synaptic cleft and cannot produce its therapeutic or the pharmacological effects. And after that, the last you can say that inhibitor, or a lot of you can say that inhibiting factors, that even the acetylcholine now it is in the vesicle form. Okay, it is stored into the vesicle forms or the granule forms, but now it has to release into the synaptic cleft. But if the pupil or some of the patients who have excessive magnesium, means they are suffering from hypermagnesemia, they have lack of calcium, means they are suffering from hypocalcemia, they have used some type of the local anesthetics, or if they are suffering from some type of the botulinum toxins, means they are suffering from some type of the food poisoning, bacterial food poisoning, then ultimately this acetylcholine it cannot comes into the synaptic cleft, and ultimately it cannot bind to the muscarinic receptors or the nicotinic receptor, and ultimately it will not produce its pharmacological or the biological effect. So everybody's clear still now the synthesis of acetylcholine, its release, its storage, its function with the effector organs, what are the inhibitors at the carrier level, at the enzyme level, at the storage level, and even you can say that at the exocytosis release level. So thank you very much. If everybody is clear, then we are coming towards our next talk, which is very much related to the acetylcholine action. So what are the acetylcholine actions? So if you see the actions of the acetylcholine, they are reverse of the neurotransmitter norepinephrine, you can say. So thank you, Mr. Vleed and Mr. Turkey. It means that now you are listening my voice and you are liking my voice now, I think. Okay, so acetylcholine actions, they are just opposite of the norepinephrine neurotransmitter. If you recall your memory or memorize the things from our previous talk, as I told you that norepinephrine it causes mydriasis, but acetylcholine it will cause meiosis. There will be accommodation of the eyesight in the case of acetylcholine, but you can say that when you are fight, flight, or fright, the accommodation of your vision it is disturbed somehow. There will be the lacrimation and salivation, increased secretions when your parasympathetic system it is elevated or stimulated. The good example is that now at weekend when you will go to the Outback, mostly the saliva it would be secreted in your mouth when you will see the fresh and hot Outback KFC or McDonald's. I'm just kidding, so please pardon me or forgive me. Okay, so on the heart, they are causing decrease in heart rate, as well as you can say that decrease in the nerve impulse to the heart, bronchoconstriction, and the increased bronchial secretion. But if you see the sympathetic system, there is increased heart rate, increased blood pressure, there is bronchodilation, as well as decreased secretions, you can say. At the stomach level, you can say there is increased production of the hydrochloric acid, there is increased peristalsis movement or the gut motility, and there is, you can say that contraction of the sphincter. This is the only case that when the food is digesting and after that it has to come into the sphincter, into the small or the large intestine, that when the food is the food is digesting very fastly, then the sphincter it is, you can say that close for some time or contract for some time. But when it is properly digested, then ultimately this sphincter it has also the increased activity or the motility. And micturition, you can say that reflex it is increased in the parasympathetic state, and erection of penis in the male when they are in the relaxing or the resting phase. And these are the muscarinic actions, by the way, for this acetylcholine neurotransmitter. But this acetylcholine it has also some nicotinic actions, and if you remember that I told you in the first lesson that the presynaptic ganglia and the postsynaptic ganglia of the parasympathetic nervous system, they have the acetylcholine actions on both muscarinic receptor and the nicotinic receptors. Is everybody following me? Yeah, pre-muscarinic, you can say that. Okay, even the pre-muscarinic, or you can say that pre and post of the parasympathetic, the neurotransmitter is acetylcholine. And they have also some of the CNS actions: alertness, tremors, increase in the cranial pressure, messes, and convulsions. And this is their, you can say that, effects when we are taking some of the nicotinic, you can say that, stimulant in the form of cigarette smoking, as well as some of the other drugs, you can say that, which actually activate the cranial nerves in your adrenal medulla of the central nervous system. So everybody is still clear about the actions of the acetylcholine in our smooth muscles parameters, as well as some other parts of the body? Okay, that's fine. So now we are discussing the drugs or the pharmacology, which is our main theme, you can say that. And please, no means what is from Mrs. Ma? Is there no clear, or there is no question? Yes, question, please, Mrs. Ma. So there is a Q, so Q means question. No question. Okay, thank you. So now we are discussing our parasympathomimetic drugs. You can say that when we are saying the parasympathomimetic drugs, it means that these are the drugs which actually stimulate our cholinergic system. Either it is direct acting, either it is indirect acting. So now I want your focus or intention here, because this is a very important concept here. If you see our sympathetic nervous system, I told you that in sympathetic nervous system there are some of the reuptake phenomena to in the nerve termini of the norepinephrine after producing their pharmacological biological functions. But this is not the case in the parasympathetic stimulation of the nervous system. So what it means, that it means that definitely you have the drugs which actually degrade the enzyme by which acetylene makes a complex, and after that it is degraded. So there are two types of the parasympathomimetic drugs. One is the direct acting and the other is the indirect acting. So first of all, what are the drugs? What are the parasympathomimetics? These are the drugs that facilitate or mimic some or all of the actions of acetylcholine on cholinergic receptors. So means these are the drugs which actually stimulates or mimic the functions of acetylcholine onto the nicotinic, or you can say that the muscarinic receptors of all actions of this acetylcholine into smooth muscles, as well as you can say that in some part of the adrenal medulla. So if we see the direct acting parasympathomimetics, these are the muscarinic agonists, acetylcholine and the pilocarpine. And there are some nicotinic agonists, nicotine. So what it means that here now, it's a very important clinical pearl for you pupil. As I told you that the preganglionic and postganglionic nerves of parasympathetic system, they have one neurotransmitter, that is acetylcholine. So what it means, that it means that either the receptor is nicotinic, but here the action is produced by the acetylcholine. The pharmacological actions, these are produced by the acetylcholine neurotransmitter. So it means that even you are using the nicotinic agonist, that is nicotine, it actually enhances the function of acetylcholine, because most of the preganglion and postganglion nerves of the parasympathetic nervous system, they have the acetylcholine neurotransmitter. Either you can say that these are the muscarinic receptor or the nicotinic receptor. Everybody is clear about the direct acting? Any question? Okay, and there are some indirect acting. So what is the nicotine is a drug? Yeah, nicotine is a drug, and cigarette smoking, you can say that, contains cigarette, it contains nicotine, And some of the nicotine, you can say that it is used in the experimental animals as well as in the humans, just to stimulate the central nervous system, specifically in some type of the pre or post operative surgeries. It's not used now, you can say that, but still on the experimental basis, you can say that some of the doctors and some of the physicians, they use this nicotine just to you can say that alert or to stimuli. No, I am not saying this that the nicotine it will enhance the functions of acetylcholine. No, my point is that the acetylcholine, it is a neurotransmitter in preganglionic and postganglionic parasympathetic nerves. Okay, so it means that the receptors, they are muscarinic and nicotinic. The receptors are muscarinic or nicotinic, but the neurotransmitter, it is acetylcholine. Means acetylcholine, it is producing its pharmacological effects in both muscarinic as well as on the nicotinic receptors in the skeletal muscle, in some of the skeletal muscles. I'm not talking about the nicotine. Nicotine, it will only produce its effect onto the nicotinic receptor. It will not produce any, or you can say that greater amount of effect onto the muscarinic receptors. You can say that it will it will only, you can say, that produce its effect when it will stimulate the nicotinic receptors. It will not produce any effect onto the muscarinic receptors. But this acetylcholine, as I told you, it can stimulate both muscarinic and nicotinic receptors. And indirect acting, you can say that it will act on the enzyme that is anticholinesterase. And if you see this slide, I can show you here. Yes, if you see this enzyme, I told you that when acetylcholine it released into the synaptic cleft, it produced its pharmacological effects while binding to the nicotinic and muscarinic receptor. After that, there is excess acetylcholine. So there is no reuptake as we have seen in the sympathetic nervous system. So what it means that this excessive, yeah, that's yes, Miss Aziza, that the acetylcholine, it acts on both muscarinic and nicotinic receptors. Muscarinic in smooth muscles and nicotinic in some of the skeletal muscles, because it is both pre and post ganglionic, you can say, that neurotransmitter of the parasympathetic nerves, you can say. So I am talking about the indirect acetylcholinease esterase inhibitor. So the excessive acetylcholine, it will bind to this enzyme, and then it will be degraded into acetate and into the choline. But if we have some drugs, you can say that, which are actually the indirect acetylcholinease esterase inhibitors, like neostigmine, it will actually make a complex with this enzyme, and ultimately acetylcholine, it cannot bind to this enzyme for degradation, and there will be more acetylcholine in the synaptic cleft, and it will actually, you can say that, binds to these two receptors again and produce its pharmacological or the therapeutic effects. And if you see here in the indirect acetylcholinease inhibitors, we have the example of this neostigmine. Everybody is clear about the, yes, we will discuss about the pilocarpine. Yes, it is a muscarinic agonist. Pilocarpine is a drug. Acetylcholine is a neurotransmitter, but acetylcholine itself acts as a drug, you can say that, in people who are suffering from some type of the disease we are seeing in the next slide. So if we see the direct parasympathomimetics, there are two classifications. I do not understand the muscarinic agonist. Okay, so no, it's not a competitive inhibitor. Just please go into the this slide again. I'm so sorry that what is happening with this. I think the blackboard is also so much exhausted. Just give me a minute so that to make the settings, there was a problem. I don't know why it's a problem. I just make refresh my system. I just check. Yes. So if we see the parasympathomimetics, I told you people that these are the drugs which are actually the stimulants. They actually stimulate the actions of acetylcholine on cholinergic receptors. Now, cholinergic receptors, they are two, muscarinic as well as the nicotinic, you can say that. Okay. So what it means that when we are using the direct acting parasympathomimetics, it means that these are the drugs like acetylcholine and pilocarpine, okay, and nicotine. So my point is that when we are using the direct acting muscarinic agonist, they will stimulate the action of acetylcholine both in muscarinic and nicotinic, because I told you that the presynaptic and postsynaptic ganglion of the parasympathomimetics, they have the acetylcholine, a neurotransmitter, to produce their pharmacological effects. Okay, but the nicotinic agonist, nicotine, it will only produce or stimulate the nicotinic receptor. It will not, you can say, stimulate the muscarinic receptor to produce any type of the effect. Here nicotine is a drug. Here nicotine is not a neurotransmitter. Nicotine is a drug. We have only two neurotransmitter, acetylcholine in the case of, you can say, the parasympathomimetics stimulation, and norepinephrine in the case of sympathetic stimulation, you can say that. Okay, so nicotine, it acts as a drug, you can say that. It actually, you can say that, active the nicotine receptors. And indirect acting, as I explained you people, that some of the enzyme, you can say, which is very much related to the degradation of this acetylcholine, neostigmine is a drug which actually bind to this receptor, and ultimately then acetylcholine, it cannot make a complex with this receptor, sorry, this is enzyme, and it will not degrade it, and it will produce its pharmacological effects while binding to the muscarinic receptor or as well as to the nicotinic receptor. So now it is clear. Okay. So if we see the direct parasympathomimetics, we have two types of the classifications, chemical classification. One is the choline esters in the chemical composition. This is acetylcholine, carbachol, and bethanechol. Some of them, they are the cholinomimetic alkalides, and some of them, they are the alkalides like pilocarpine. So they actually stimulates muscarinic receptors with long duration of action. So these drugs, they have the long duration of actions. A carbachol, it has the muscarinic and nicotinic actions. Like now you are clear. Now you are clear that some of the direct parasympathomimetics, they actually act on both muscarinic as well as on the nicotinic receptors, but the neurotransmitter is acetylcholine in both cases to produce their pharmacological effects. Now everybody is clear. Okay, thank you very much. They are used in glaucoma. What is glaucoma? We will discuss in detail in the next slides. Paralytic ileus and urine retention, or urine retention, you can say that. Paralytic ileus is actually a disease in which you can say that there is some type of inflammation of the small intestine, you can say that, or there is some obstruction of the small intestine, that when the food is passing from your stomach into the small intestine for absorption, small intestine muscle, they are not working properly, you can say that, or the muscle tone is weak. It is called actually the paralytic ileus. So these direct parasympathomimetics, they are used to treat the paralytic ileus, glaucoma, as well as the urine retention. That means some people, we will discuss in the next slides that they have this habit at the bedwetting, and even the children, our infants and children in their age of 3 or 4, they have the habit of bedwetting, means they have the increased urination in the sorry, in their bedroom at night and even into the day. At that time, you can say we have to use some type of the drugs just to control their there is a one question from Ms. Jamana or Jamama. I don't understand. Can you write it again, or can you speak to repeat this question? So urine retention, you can say that the people who are suffering from the more urination or more micturition reflex, then ultimately we can use some of the drugs, direct parasympathomimetics, just to retain the urine, you can say that. Or in other words, you can say that their urinary bladder and sphincter, they are loose. These drugs, they actually control that looseness so that they don't have the urination reflex at every time. So everybody is clear about the direct parasympathomimetics. We are coming towards the indirect parasympathomimetics, and I think that Miss Jemina or Jemama, she can find the answer of her question. Sorry. So indirect parasympathomimetics, they are also called the anticholine esterase. So as I told you earlier, that this enzyme that is called choline esterase, it actually degrades the excessive choline, acetylcholine in the synaptic cleft when it has produced all its pharmacological or the biological actions, you can say that. But if we have these type of drug, they will actually binds to those enzyme that is choline esterase, and ultimately there will be more production of, or the more accumulation of acetylcholine into the synaptic cleft, or to make a binding with the receptors and produce the therapeutic effect, biological effect, or the pharmacological effects. So if we see acetylcholine is the enzyme degradation. Yeah, acetylcholinease esterase enzyme. It is an enzyme which actually degrade the acetylcholine. You understand? But if we are using some drugs which make a complex or binding with this enzyme, then ultimately acetylcholine, it cannot be degraded into the synaptic cleft, and ultimately there is more production of, or the more accumulation of acetylcholine into the synaptic cleft, and ultimately it will produce a long effect on the binding with the muscarinic and the nicotinic receptors, which is in the form of convulsions. I think you can better understand when we discuss the reverse anticholinease esterase and the irreversible anticholinease esterase inhibitors. If we see the reversible anticholine esterase, they are the neostigmines and physostigmines. So what it means that these drugs, neostigmine and physostigmine, they bind to the enzyme for some time and ultimately produce the pharmacological effects. They are used in the myasthenia gravis, intestinal atony, and glaucoma. So first of all, you must know that what is myasthenia gravis. Myasthenia gravis, it is actually a type of disorder, you can say it is a genetic disorder in which, if you see the people who are suffering from this myasthenia gravis, please, I am sorry, just to make the arrangement. Yeah, myasthenia gravis, it is actually a neuromuscular disease. If you see the people who are suffering from this type of disease, they have muscular weakness. The most commonly affected muscles, they have their eyes, face, and swallowing. Means if you see those people who are suffering from this myasthenia gravis, they are suffering from the loose, you can say that, movements of their muscles of eye, face, and you can say that swallowing. Okay, and most of the time they have the clinical sign and symptoms in the form of double vision. Their vision is disturbed, their drooping eyelids means they cannot blink their eyes, and even they have trouble in talking, and you can say trouble in walking, you can say. So in myasthenia gravis, you can say there is deficiency of this acetylcholine. Then ultimately you can say that you have to provide more acetylcholine to bind to the neuromuscular nicotinic receptor, as well as to the muscarinic receptors, to produce the normal contraction and relaxation of the smooth muscles, as well as the neuromuscular the muscles in the you can say that skeletal muscles, like you can say that in the legs or in the hands or in arms. So this is, you can say that the drugs, reversible anticholinease esterase, which are very much used for the treatment of the myasthenia gravis. And then it is also used in intestinal atony. What is intestinal atony? Intestinal atony means that the muscles of your small intestine, they lose their contraction. Means you know that when we have taken our food, our stomach and our small intestine, there is the motility of the walls of the stomach as well as the small intestine to digest the food and absorb the food. So when the people who are suffering from this intestinal atony, they have the loose movements of their intestine due to the weak muscular movements, you can say that, and it has lost its strength, you can say that, for the normal contraction and relaxation, you can say. So it is also called intestinal atony. And glaucoma, you can say that there is increased pressure onto the iris and cornea of your eye, that there is one liquid that is called actually vitreous humor, which actually make a pressure on your cornea and iris of the eye. So you have a problem with your vision. We will discuss in detail at the end of this session. So everybody is clear now. The reversible anticholinease esterase used in these three type of condition in myasthenia gravis, intestinal atony, and glaucoma. Is there any question still now? Is there any question from any side? Okay, thank you. Uh, Now there is some other, you can say that indirect parasympathomimetics, which is irreversible, means they actually make a complex or covalent binding that cannot be, you can say that reversed, that cannot be depleted until we are using some type of the antidote. Is there any question from Miss Asma? Yeah, glaucoma, I will repeat in detail in the next few slides. Don't worry. We have glaucoma, its type in the end of a few slides. You can say that 2 or 3 slides. Don't worry. So I will explain the glaucoma. What is the difference behind two drugs means neostigmine and physostigmine? I will also let you know in the next last slide that what is neostigmine and what is physostigmine. Don't worry. So we have also irreversible anticholinease esterase inhibitors, you can say. So anticholinease esterase are antagonist. Yes, it is antagonist for the enzyme, but they work as a stimulant. Clear? They work as an enzyme stimulant, but they are antagonist to the enzyme. You are right. So irreversible anticholinease esterase, these are the organophosphorus compounds. Some of the organophosphorus compounds, they are used as insecticides, and you know that the insecticides are the drugs which are very much used to kill the insects, like cockroaches. In our kitchen, the females, it's the side of the female, you can say the work is transferred to the female side. Then sometimes we have the cockroaches in our kitchen. So to kill those cockroaches, we are using some type of the spray. This spray actually contains some of the organophosphorus compounds. So these organophosphorus compounds, they actually make irreversible binding or a covalent binding with this enzyme, that is acetylcholinease esterase. And then ultimately this binding, it cannot be depleted, it cannot be reduced, it cannot be decreased. Then ultimately there is more accumulation of acetylcholine into the synaptic cleft, and ultimately there is more convulsions, and ultimately there is death. One example I can quote here, if you remember that, I think in 2014 or 2016, Bashar al-Assad, he actually fired the nerve agents into some of the pupils in Halb, in Syria. So those drugs were actually also the irreversible anticholinease esterase inhibitors. And if you see the pictures and the movies of all those pupils who were infected, they have the continuous convulsions, they have the continuous contraction phase of their muscles, of their bronchi, of their lungs, you can say that, of their heart muscles, smooth muscles, then ultimately they have the death. So most of the organophosphorus compounds, which are actually the irreversible anticholinease esterase inhibitors, they are used as human poisoning or for the suicidal tendency, you can say that. Okay, in some part of the world, in the third world countries, like poor countries, Pakistan, India, Bangladesh, and in some type of the African countries, most of the people who have to commit suicide, they are actually using the organophosphorus compounds just to make or commit the suicide. So everybody is clear now about the irreversible anticholinease esterase inhibitors. Is there any question still now? Okay, then we are coming towards parasympathetics, anticholinergics. First, we have discussed the parasympathomimetics. Now we are discussing the parasympatholytics, means muscarinic and nicotinic antagonist. Now here we have a very clear demarcation or very clear classification that the muscarinic antagonist, they will only act on to the muscarinic receptors, and nicotinic antagonist, they will only act on to the nicotinic receptors. So if we see the muscarinic antagonist, they are the atropine and its substitutes, and the nicotinic antagonists, they have the two classifications. One is the ganglion blockers, and the other is the neuromuscular blockers. And if you remember in the first 2 or 3 slides, I told you that the nicotinic, you can, that receptors, they are present in the ganglion, central nervous system ganglion, as well as into the neuromuscular or the skeletal muscles of our body. So if we comes towards their classification, first we will go towards the muscarinic antagonists. So if I come to the muscarinic antagonist, so muscarinic antagonists, they are used in colics, asthma, anaurosis, Parkinsonism, bradycardia, eye inflammation, and organophosphate poisoning. So what is colics? Anybody know what is colics or what are colics? Abdominal pain, yes, Mr. Mars. It's not a syndrome, Mr. Bleed. From female side, anyone know what is colic? So now the females are lethargic. I think they are feeling exhausted. Huh? So colics is actually a severe abdominal pain, and it is most of the time seen in the infants or children when they have taken their formula milk or sometime the breastfeeding. Their stomach is, you can say, it becomes bulky and stiff due to the accumulation of air in their stomach and in particular into the intestine. So this actually, you can say, that cause colics into the babies, and sometimes believe me, it is very severe that if it is not treated timely. So most of the muscarinic antagonists, you can say that they are used to treat the colics in infants, as well as you can say that even into the adult patients. Asthma, you know that muscarinic antagonists, they will use just to decrease the secretion as well as to cause bronchodilation. And yes, this is the flatulence pain, you can say that one of the females is a very good response, that is the flatulence pain, you can say that pain due to the air inside your stomach as well as in the intestine. And the muscarinic antagonists, they are also used in enuresis. So enuresis, as I explained you earlier, that enuresis, it is actually the increase urination reflex or increase urgency of the urination to produce urination or to do the urination, and it happens both in children as well as in the adults after the age of 60 or 65, when their urinary bladder, you can say, the contraction and relaxation is compromised, you can say that in both cases. And it is also seen in some of the pregnant females when they have to you can say that delivered the babies, and they're going for the C-section. Then ultimately some of the, you can say, the sphincter muscles of their unibladder is also relaxed, and they have also this type of the problem enuresis. That means when they are doing some cough and when they are doing some type of the laughing, you can say the urinary bladder contraction, it is not compromised, and the sphincter of the urinary bladder is, and they have some drops of the you can say that urine. So it is a two types of enuresis. One is the nocturnal enuresis, means the pupil or the babies who have the increased urination in the night time, and the other is the diurnal enuresis, means some of the babies, they have the habit to do more urination in the daytime. So some of the muscarinic antagonists, they are also used just for the treatment of this enuresis. And Parkinsonism, you know that Parkinsonism is a specific type of muscular disorder in which there is a slow movements of the body organs, as well as you can say that some skeletal muscles of the body as well, and it happens due to the deficiency of a neurotransmitter, that is dopamine, in some of the higher center of your central nervous system. And in bradycardia, we can also use some of the muscarinic antagonist. In eye inflammation, if there is some type of increased secretion or there is some type of lacrimal problem in the eye, then we have to use the muscarinic antagonist. And some of the organophosphate poisoning, to relieve the symptoms of organophosphate poisoning, we can use some type of the muscarinic antagonist. And if we see the muscarinic antagonist classification, yeah, inhibit ADH. Yes, you are right. Yeah, it is the antidiuretic hormone, Miss Asma. When we have to treat this enuresis in children as well as in the elderly patients. So we have two type of classifications of the muscarinic antagonist. One is the natural belladonna alkaloids, atropine and hyoscine, and now we have some synthetic atropine substitutes. The reason for this synthetic atropine substitute is why, because now the belladonna, or sorry, the atropine hyoscines, they are the natural compounds, and they have the therapeutic monitoring of drug dose is very critical in this atropine or hyoscine administration, because itself it can produce severe side effects in the administered patients if you are not monitoring the dose. Dose is very critical, and most of the atropine and hyoscine, it is in form available in the form of tablet, but this atropine, it is available in the form of parenteral preparation, the form of some injection form. So the bioavailability of the drug, it is 100%, so it may cause some type of the harm. But the synthetic one, you can see that they are more stable. They are available also in the form of some tablets or capsules, and they are more prolonged in action as compared to the atropine, and their side effects are fewer or the less. So if we see the synthetic atropine substitutes, the first one, it is the anti-secretory or antispasmodics. I mean, just to relieve the abdominal pains. There are two drugs, that is propenthyline and prenazepine. There are some midretics, means just to you can say that treat the glaucoma. It is the tropicamide. There is some anti-Parkinsonism drug, that is benztropine. There are some anti-aneurysis drug, that is amiporinium, and there are some anti-asthmatics, that is ipratropium. Yes, we are discussing about the synthetic atropine substitute. Yes, I mean, nowadays we are, or in the clinical or the hospital setting, most of the muscarinic antagonists, they are used in the synthetic atropine substitutes. We are not using the natural belladonna alkaloids or some type of the other natural forms of these muscarinic antagonists. Then we are coming towards the drugs which are nicotinic stimulants. And if we see that the nicotinic stimulants, I am so sorry, again the system is on. Yeah, nicotinic stimulant, they actually increase the activity of acetylcholine on nicotinic receptors, both in the autonomic ganglia as well as, you can say that, into the skeletal muscles. And as I told you that this NN receptor, it is in the autonomic ganglia of the central nervous system, but this NM, it is into the skeletal muscles. So some of the parasympathomimetics, you can say that it is acetylcholine, carbachol, and neostigmines. And as I told you earlier, that some of the parasympathomimetics, they are also acts on the nicotinic receptors. The neurotransmitter is same, but the drugs, you can say that they are the parasympathomimetics. Yeah, I am so sorry that I could not have a picture, but I think you can understand the things if you will recall the that picture which is giving the innervation. I am so sorry that I don't have any picture still now. So the selective non-nicotinic agonist, we have the nicotine. It is present in the cigarette smoking. And about the cigarette smoking, I will let you some interesting figure. 1 year or 2 years before, there was a research that if a person who is using one pack of cigarette daily, he or she can decrease his or her life 16 minutes. So just imagine that if you are consuming nicotine from cigarette, then ultimately you are decreasing your life 16 minutes a day. So please means uh, aware, spend or spread the awareness that smoking is injurious to health in the community, being a professional. So, okay, so if we are talking about the nicotinic blockers, as I told you that they are the ganglionic blockers as well as the neuromuscular blockers. So when we are saying the ganglionic blockers, they have two types of mechanism. One is depolarizing and the other is the competitive, and same is the case with the neuromuscular blockers, that they are the depolarizing and competitive. What it means that depolarizing? Yeah. What is the difference between parasympathomimetics and nicotinic receptor and agonist? Yeah, there is only the difference of the drug. When we are saying that the parasympathomimetics, as I told you earlier, please try to memorize this concept. I told you that parasympathomimetics, these are the drugs which can act on both nicotinic and muscarinic receptors to produce their parasympathomimetic effects. These are the parasympathomimetics. So parasympathomimetic drugs, they can act on both nicotinic as well as onto the muscarinic receptor. But when we say the selective nicotinic agonist, it means that they only affect onto the nicotine receptors. They will not have any effect onto the acetylcholine receptors, muscarinic receptors, acetylcholine receptor, the muscarinic receptors. So please, I can give you a very good example here. The people who are doing cigarette smoking, so in cigarette there is nicotine. So if you see the biological or the physiological effects, it is of nicotine. Okay, those people who are using cigarette smoking, they have the skeletal muscle effects, you can say that. Okay, they don't have any effect onto the muscarinic receptor, you can say that. Although we know that the cigarette, it causes cancer, but just imagine that the people who are taking smoking, they don't have the, you can say that, mydriasis. They don't have the increased secretions, you can say that, which are the functions very much related to the muscarinic receptors. So nicotine, it has only specific actions onto the nicotinic receptors, but parasympathomimetic drugs, they have effects on both, either on the nicotinic receptor as well as onto the muscarinic receptor. Is everything is clear now? Is everything is clear about the nicotinic stimulant? Yeah, nicotinic stimulants, they're specific, you can say that, but parasympathomimetics, they are not specific, you can say that. They can produce their pharmacological effects even onto the muscarinic as well as onto the nicotinic receptor, because the neurotransmitter is same both in muscarinic and nicotinic receptors. So nicotinic blockers, I told you that they have the two mechanism, one is depolarizing and one is competitive. So what it means that actually, when the people who are the chain smokers means consuming 2, 3, or 4 packets of cigarettes per day, and they're consuming nicotine in large dose, ultimately the depolarization state of their action potential, it is decreasing. Means these nicotinic blockers, like nicotine in large doses, it actually block the conduction of action potential from the central nervous system. There they actually block the action potential active phase, depolarization. And some are the competitive, means they actually compete for the nicotine, that either nicotine, it will bind to the receptor, or either this drug, that is trimethophan, will bind to the receptor. It is a competitive, which one will increase in the dose, then ultimately it will produce the pharmacological effect. And same is the case at the neuromuscular blocker, where the receptor is muscarinic or neuromuscular receptor, sorry. When there is a nicotinic muscular receptors, the same phenomena, depolarizing and the competitive. Here is the succinylcholine drug, which actually cause the block the depolarization state of the action potential. And one is the competitive antagonist at aquarium, means it will compete for the neurotransmitter, that is nicotine, or nicotine in the large dose. Everybody is clear? Okay, after that we will see that what are actually the neuromuscular blocker use. In the next slide, neuromuscular blockers, they block nicotinic receptors. Now you are most clear. Neuromuscular blockers, they are selective, agonist or antagonist. They block nicotinic receptors at motor and plate, producing skeletal muscle relaxation. Means most of the nicotinic receptors, they are in the skeletal muscles. So when they are blocked, then ultimately there is a skeletal muscle relaxation, and this relaxation, it is produced during anesthesia, and we have to go for some type of the post surgery or pre or post operative surgery. Then ultimately we need the anesthesia. So ultimately you can say that some of the neuromuscular blockers, they are used as a adjunct therapy, just to paralyze the muscles, you can say that, or just to reduce the contraction of the muscles by some of the neuromuscular blockers. And we have two types of the neuromuscular blockers which are used in the anesthesia or a smooth muscle, skeletal muscle relaxation. One is the competitive and the other is the depolarizing. So if we see the competitive, they are the D-tubocurarium, atraconium, and the vecronium. They have the long duration and useful during surgery. This was one question, the duration of the neuromuscular blockers. So this is the answer, that the most of the competitive neuromuscular blockers, they have the long duration and they are used during the surgery. But some of the depolarizing, you can say that just inhibit the action potential. They are, can you explain that in slide 4? So can I come into slide 4 again? This is 4 here. So I think this is 4. Okay. So here, if we see, this is a parasympathetic system. Okay. And if we see that all these are the muscles, you can say that here we did not have mentioned any type of skeletal muscles. But when we are talking about the nicotinic antagonist, we are talking about the skeletal muscles, you can say that. Okay. And skeletal muscles, most of all, they are involved in your movements, you can say that. The arm movements, hand movements, you can say that, your leg movements, joint movements, all those, you can say that. So we cannot explain here, you can say. Actually, I can show you here. I think there is one question, but I cannot see the questions. Please, can you write the question again? Can you write the question again? Some of the female, I think she was asking some question that, but I could not answer. See the question, you know. I just see from here if I have the access to see here, because when there are a lot of messaging, you know, the chat box is filled and it is under pressure. That it is a huge burden, you can say. Okay. Anyway, so competitive, you can say that neuroblockers, they are used during surgery. They have long duration of action, and actually they relax the skeletal muscles. Yeah, yes, the competitive, yeah, there is some difference between competitive and depolarizing. Competitive means they will act on the nicotinic receptor. They will not depolarizing the action potential. Competitive, they will act on the nicotinic receptor to relax the skeletal muscles. NM receptor, you can say that. Okay. In skeletal muscles, long duration, useful during surgery. Depolarizing means like succinylcholine, they will actually reduce the action potential, okay, which is coming from the spinal cord or even from the central nervous system. And they are short duration and they use in the tracheal intubation, means when you are going for some type of endoscopy and the doctor is inserting some type of the tube inside your stomach, then ultimately you have some pain, feeling of pain or sensation of pain or inflammation in your nose and in your mouth. Then ultimately you have to use this succinylcholine just to relax the muscle so that there is no pain or the inflammation. After that, I think this is the answer of that lady question, is that comparison between competitive and depolarizing neuromuscular blocker. No, competitive acts on receptor. Yes, competitors, they are acting on receptors, but the depolarizing, they are actually reduce the action potential. So if we see the competitive, they are non-depolarizing. This is the question of that lady. And depolarizing, they are non-competitive. Example is the Corair or DTC. DTC is a D-tubocurarium, the short name of the drug. Succinylcholine, it is a depolarizing. Mechanism of action, they compete with the acetylcholine. Now this is the answer of most of you people, that acetylcholine, it is a neurotransmitter even into the nicotinic receptors, and they act the competitive, they, you can compete for acetylcholine, but the depolarizing, you can say that they actually maintain the depolarization, means they act like just acetylcholine, you can say. Nature, they are the antagonist. Most of the competitive, they are antagonist, but the depolarizing, they are partial agonist, means they actually stimulate the repolarization state more than the depolarization, you can say that. Muscle action, they are paralysis without twitches. You know what is twitching? Twitching means that the involuntarily contraction of your muscle. Sometimes, you know, sometimes your eye, left or right, it has some you can twitching of the muscles, you can say that, uncontrolled or involuntarily contraction of the muscles, it's called actually twitching. And here in the competitive antagonists, first there is there is paralysis without twitching. There is no twitching of the muscles, but in depolarizing, there is the muscles, it will twitch, and after that, it is the paralysis or the relaxation of the muscles. So neostigmine, you can say that it is a drug which may act as antagonist, competitive antagonist in the case of these competitive neuromuscular blockers, but it is a potentiate effect into the depolarizing neuromuscular blockers. Everybody is clear? Okay, that's fine. Now we are starting glaucoma. What's the glaucoma actually? So glaucoma is actually a set of eye disease caused by the intraocular pressure, and this intraocular pressure, it is due to a fluid which actually runs between the iris and cornea of your eyes. Okay, this is called actually aqueous humor. So when it is blocked due to some reason, then ultimately it may affect your vision, you can say that. Okay, so your peripheral vision or your vision accommodation is disturbed, you can say that. Means from the side, your side vision is disturbed, means you can see the straight things, but your side vision is disturbed. You can have focus on the side, on the left side or the right side clearly, because when we see even the straight, ultimately we have some vision from the left or the right side of our objects, you can say that as well. So when there is a problem of this you can say that drainage, that means the flow of the fluid between iris and cornea of your eye, then ultimately you can say that we have a glaucoma. And when you can say that there is a blockage of this fluid to clear, it is called actually decreased drainage of aqueous humor or the closed angle glaucoma. And when there is increased production of this fluid aqueous humor, then ultimately it is also a problematic that it will create more pressure onto the iris and cornea. It is called actually the open angle glaucoma. And we have some drugs like parasympathomimetics. These are the myotic drugs, pilocarpine and physostigmine, used for the glaucoma. There are some carbonic anhydrase inhibitors. These are the diuretics like acetazolamide, which is used to treat the glaucoma. There are some sympathomimetic drugs, that is dapivirine. It is actually a experimental drug. It is not clinically used to treat the glaucoma. There are some beta blockers like timolol, and there are some surgical, you can say that, treatment by the removal of the iris of your eye, so that the drainage of the vitreous humor, aqueous humor, sorry, it must be easily flow, and ultimately there is no pressure on the cornea. And at the end we have, I'm so sorry that I have to complete the things in a very quick manner, but I hope that the glaucoma, most of the things you are understandable. And maybe I think in some of your physiology and anatomy, if in some of module you have a detailed discussion about this glaucoma as well. So the last, there is some MCQ that a 37-year-old woman, she has blurred vision, double vision after 8 hours eating home preserved peppers. 6 hours later, she has dysphagia, dry mouth and eyes, progressive weakness of the arms and legs, sorry, and urinary retention. She is awake and alert. So, which is the which of the following is the most likely mechanism of these observed effects? So, if you see all these options, I will start from the descending to sorry, from the ascending to descending, like inhibition of G proteins. So if you see the mechanism of all the sympathetic nervous system and the parasympathetic receptors stimulation, there is no involvement of the G proteins. Some they are stimulated by increased influx of calcium. Some you can say that increase or decrease. You can say that involvement of the cyclic AMP. There is no, you can say, inhibition of G protein involved in such type of the case, where the female, she has the dry mouth and eyes. She has a dysphagia, means the problem in the digestion of the food as well as the urinary retention. So this option is not suitable. Inhibition of cholinase esterase activity. If there is more inhibition of cholinase esterase activity, it means that there is more acetylcholine in the, yeah, G protein is actually some type of protein which activates cyclic AMP. It is not you can say cyclic AMP. It is a molecule. It is you can say that chemical compound, but this G proteins, they are specific proteins inside the cells. So if there is inhibition of this cholinase esterase activity, then ultimately more acetylcholine into the synaptic cleft, and ultimately there is more secretion. So the female has dry mouth and eyes, so it means that this option is also not good. Okay, so antagonism of muscarinic receptor, if there is more antagonism of muscarinic receptor or the nicotinic receptor, then ultimately there is more acetylcholine, and then ultimately you can say that the patient has the convulsions or the continuous contraction of the relaxation of the muscle. But here the female, she's suffering from weakness of the arms and legs. So it means that the acetylcholine, it is not properly producing, it is not properly releasing, and it is not properly, you can say that, bind to the receptors to produce this type of the therapeutic effects, or the, sorry, the pathological effects. So it means that the C option is the best answer, because when there is no acetylcholine, then ultimately there will be the weakness of arms and legs, there will be dry mouths and eyes, there will be the dysphagia, the movement or the motility of the GIT, it would be slowed down. In summary, you can say that we have discussed today the cholinergic muscarinic receptors are involved in the parasympathetic actions. Muscarinic receptors, they are activated by acetylcholine and blocked by atropine. Nicotinic receptors, they can be blocked by depolarizing and competitive agents. And parasympathomimetics, they are useful in the treatment of glaucoma and myasthenia gravis. And there are some of the reference books for you people. One is from the Basic and Clinical Pharmacology from this Katzeng, and the other one is Lippincott from some of the renowned scientists like Karen Wellen. So thank you so much for all of you to listen me very patiently. And if you have any question, we have 3 minutes to end the session. I can give the answer of your questions. If there is any, you can see that question. If there is any comment, please let me know. And hopefully you will enjoy your dinner at night, and you will memorize the things for our parasympathetic nervous system, that when you are in a state of enjoyment as well as relaxing, and you can say that a state of feel pleasure. So thank you very much to all of you. If you have still any comments, we have 2 minutes to end this session. Any question from male and female side? Yes, I can send my number, Mr. Mars. Okay, even I have the symptoms of illness. It is not the job of pharmacology. I think it is the job of some of the pathology, and I hope that inshallah you have some of the pathological courses or modules. So I am sending you people my email as well as my mobile number, because Mr. Mozi has requested me. So please, if you have any difficulty, if you have any problem while to listen me, while to have problem in uh, compelling the things, the hurdle, something a hurdle, please let me know. So I have sent my number as well as my email. So if you have anything, please let me know. So thank you very much. Assalamu alaikum, and have a nice weekend. No, depolarization, it will only affect on the action potential. It will not affect the acetylcholine. It will actually delay, or you can say that increase the depolarization state, or even you can say that the repolarization state. So depolarization, it has no concern with the receptors. You can say that depolarization means the action potential, or you can say that the stimulation which comes from the sympathetic system or parasympathetic nervous system, from your central nervous system, or even from the spinal cord. So it is in the form of action potential, you can say. So is it clear? So thank you very much, all of you. So nice of you, and best of luck for your I think on the next Thursday you people have the examination, and then inshallah I am hopeful that inshallah I will also see you people in the module B as well for some of the lectures. So thank you very much, and please, if I was very slow, very fast, something is not clear, my pronunciation is not clear, I have made some of the jokes, if I have some of the wrong pronunciation of male and female side names, please pardon me, excuse me, and thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.